All right. Well, thanks everybody for joining this webinar. I'm really excited about this topic. It's all the buzz right now. And I was thinking about kind of my first exposure to something AI-like, and it was when I was a little kid and I watched 2001 for the first time and saw the HAL 9000 control all aspects of the mission to Jupiter before it killed all the astronauts. And I think the message was clear: don't let computers get too smart. And then you fast forward to today, and AI is everywhere. There's an explosion of AI companies, and in all sectors of society, AI is, moving in, and we hear a lot about its potential, but we also hear a lot of doom and gloom stuff about the technology. We hear how it's reshaping schools and how universities are struggling with how to assign essays in the age of Chat GPT. And if you believe headlines like you see in the New York Times, eventually AI will do like HAL did to the astronauts and end the world. But we also know that there's just an awful lot of misunderstanding around it. There's a lot of hype, there's a lot of potential, and there's a lot of hope with artificial intelligence. And I don't think any technology that we've ever seen has been shrouded in so much confusion and excitement as AI. So with all those things in mind, we have a great panel today. And because we know all of this applies to mental health, and we have such a deep mental health crisis in our country and in our world, and there's a lot of people hoping that maybe AI could be part of the solution to helping people get the care that they need and that they deserve. Today we have three amazing panelists, and I'm just going to give very, very short introductions for all of them so that we can get right into the discussion. We have Fionn Delahunty, and Fionn is the co-founder of Lua Health, which is a clinically designed AI-powered solution to measure and manage corporate well-being. We have Alidad Ghiassi, and he is the chief medical officer and co-founder of HIA Technologies, and HIA is developing physician-controlled artificial intelligence. We'll let him tell you what that means in just a little bit. And it's delivered to patients using interactive virtual human technology and embodied AI. And then we have Tom Insel. Tom is a psychiatrist who served as the director of the National Institute of Mental Health before he became one of the leading voices on mental health technology when he left NIMH and went to Verily Google. And he has founded and advised many, many different digital mental health startups. So thank you all for being here. And I'm going to ask some questions and really just kind of let us go from person to person, because I think you all have a different perspective on things. So Alidad, I would like to start with you. And the question is that, as I mentioned in my introduction, AI is often misconstrued as only being a virtual therapist. So people talk about AI and mental health, and they think, oh, I'll sit down with HAL 9000 and we'll do therapy together. But that's really not, what we're necessarily talking about when we talk about artificial intelligence and its functionality in the space. So I'm just wondering, how do you see AI benefiting mental health technology beyond just something like a virtual AI therapist?
Well, thank you so much, Matt, for inviting me. And that's the first question that comes up when we're talking about artificial intelligence. I think it's important to keep in mind that when we say the word AI, we're really talking about the new generation of generative artificial intelligence as opposed to rule-based AI. And it's a bit tricky because, that's the first thought. But when you look beyond that, there's so many other uses for this type of technology. I think in data analytics, identifying patterns in diagnosis, especially sentiment analysis and other similar tools like semantic similarities, those are important uses for it. Predictive analytics for treatment as well. Knowing what's going to potentially happen with a particular patient and intervening before that happens. That's another useful way of using the type of this technology. And also educational patient engagement tools, which is what the space that we're in. And that's really important because for a long time, patients have been thought of as these passive vehicles in the healthcare journey, and really activating them, educating them, bringing them to a common narrative is important. Chatbots, for the most part, they're good when you first talk to them. They seem like they're sentient and they understand you, but they're just algorithms and predictive models. And it's important not to get confused by that, because it can be used for both purposes, both good and nefarious purposes. And we can dig into that a little bit more as far as model alignment, bias, transparency, and everything else. But those are the main uses that come to mind on the patient side. On the clinician side, administrative tools, for instance, EHR documentation is a big part of this challenge, and also multimodal interactions, knowing more about the patient than that's just what's in front of you. So there's lots of other uses that we can talk about in more detail, but this virtual therapist of talking to a robot, I think, is still not there, and there's a lot of barriers and ethical considerations that we have to get beyond before we can actually think that we can talk to virtual therapists and get the same outcomes that we expect from that human interaction.
Yep. It makes a lot of sense, you know, at least for the parts I understood. But I do want to circle back in a minute just to talk about, you know, the stigma, because I think that is one of the biggest obstacles that we face right now. Is a lot of, you know, existing therapists who have a lot of skepticism, saying, well, wait, AI can't do what I do, and so why are we even talking about it? But Fionn, what are your thoughts on that question?
Unfortunately, probably not radically different than what Alidad just said. I think equally so, we're probably a far way off replacing any form of therapy with anything AI related. Equally so, it would be ethically wrong probably to say there's no way here AI is going to help. We are in a mental health crisis. Globally, we do need to look at where there is gaps, where we can fill things, and where it's sort of acceptable to do that risk-reward kind of basis there. Back office administration, a lot of things I'm seeing companies doing, note-taking, scribes, documentation, saving time for the clinician, so the clinician can spend more time doing what they're trained to do and what the AI can't do, which is talking to the patient. In front of house, I think out of office services, I do see chatbots offering some support there, be it only very basic triage, but doing that 24/7 when we can't maybe always have a clinician on staff. Early stage predictive analytics, so plugging into your Fitbit, population epidemiological levels, where we have so much data that it makes sense to screen people kind of really early in the process. So I think complementarity around the therapy, we can do a lot with AI. It's still early days. There's still only a handful of companies out there that have really gone out and deployed and are testing things. We're very much at the bleeding edge here. Like every week, we're seeing new things come out. Every week, we're seeing large companies change, pivot, react. Interesting to see what the world looks like in a year's time, both in the mental health space and more generally in the AI space. But yeah, it's interesting times.
Yeah, thank you. Can you, before I jump to Tom, can you just explain a little bit more about what you're doing at Lua?
Yeah, so at Lua, we've spent about 5 years now, although everything has changed, frankly, in the last 6 months, unfortunately, over those 5 years, we've developed a suite of algorithms that can screen for mental health disorders, from voice patterns or text patterns, how you speak or how you write. Frankly, not like crazy revolutionary stuff. There's a lot of literature on this. Psycholinguistic biomarkers have been shown to be around for maybe 20, 25 years. So we've published some good research. We've added to the field a little bit, but our main tenets have always been benchmarking against clinical measures. So our algorithms output a PHQ and GAD scores, which means we can fit into a clinician workflow. We're not making up this magic number between 1 and 100. We're not revolutionizing the world. We're optimizing a thing that's already done in the clinician's workflow, and we're just doing it a little bit better and a little bit faster. And we can very easily quantify the risk and reward there. We can say we're doing it maybe 10 times faster, but 2% worse. And is that an acceptable risk reward? We work obviously with clinicians, screening. We also work with corporate clients, where our focus has always been on, I suppose, the burden of mental health is that typically you're the last person to know you have the problem. I find the Lancet did a study a while back that reported it's about 8 years from onset of depression to diagnosis, and there's many factors there. And I always think if you break your leg, you're straight into accident and emergency. you're not debating that with yourself for 8 years. Are you really bad enough to need help? So at Lua, we're trying to do more on that screening, get people into the system a little earlier, possibly at lower modalities where we don't quite need clinician involvement, but trying to prevent that crisis, try to get people help before they reach that crisis point, because that's what we're seeing now. We're seeing that everyone is waiting till they're in crisis for help, and that's really too late.
Right. That makes a lot of sense. Tom, I'll put the question to you. I think this question actually came out of a conversation you and I had not too long ago, where I remember you mentioned that a lot of people in the mental health field don't even want to have the AI conversation because they immediately think, oh, this is going to be a virtual therapist and, I'll just be in a robot's office. But it can mean a lot more than that. What are some of those things?
Well, thanks for having me here, Matt. I think this is really a timely conversation, but this isn't all new stuff. Alidad's right to say that the generative AI is a little more recent. We worked on that when I was at Google, 5-6 years ago, but it's now really come into its own in a different phase. But I think it's important, particularly for people in the mental health space, to realize that they depend on AI products all the time. If they use GPS, if they order things online, I mean, this has become part of our world. It just hasn't become part of our world in mental health care. And to Fionn's point, that'd be okay if we were doing really well. But the reality is we're failing badly. We are in a crisis, and people are not getting better, even when we have very good things to offer. So we should be asking, like, how do we do this in a way that's more effective? How do we make sure we improve outcomes? And my contributions are actually directly in line with what you've already heard. I think the idea of jumping to the chatbot and thinking that generative AI is going to replace therapists, I think there's an important conversation to have there, but that's not the first way this is going to play out. Really, what's going to matter, as you just heard, are sort of the boring administrative functions that are a burden to everybody that machines can do much better. And by that, I mean the documentation, the summaries. In a medical context, you get a 500-page electronic medical record, and you need a 200-word summary, right? You don't want to spend half the day going through that medical record. GPT can give you that within 10, 15 seconds. And so those are ways of saving enormous amounts of time, reducing the burden that I think will be critical. I'll just add a couple of things to what you've already heard that I think are applications that we're just beginning to see that are critically important. For one, I live in California, which is this remarkably diverse state. We have huge numbers of people who are not fluent in English. And so to provide reports to patients and to family members that are in translations, that are in easily understood translations, not literal translations, but translations that are conversational, could be populated with emojis, could be populated with, I sometimes put into prompts, uplifting language. I mean, there are ways of doing this that these generative tools are really spectacular at, and we need to begin thinking about that. You just heard from Fionn about the ways of using not generative AI, but old school natural language processing tools for beginning to bake in measures of mood, of sentiment, measures of coherence, measures of even stress and anxiety, which we're very good at. We've been able to do that for a decade. Those tools are finally coming of age, and it's an opportunity to move into what I call telehealth 2.0, where every telehealth interaction, every conversation has a dashboard connected to it. I advise a company called Ellipsis that has this, has used this now in care management for thousands of patients, where every time a care manager reaches out to someone with diabetes, they get the dashboard that tells them, oh, this patient's also depressed and needs to be worked up for that. Those kinds of tools ought to be just part of what we do in the world of telehealth or teletherapy. And I think the next generation, telehealth 2.0, will have that as part of a way of improving outcomes and improving quality because you're constantly capturing outcomes in your learning as you go. Something that this field has been very lax, very slow to do. The third place where I think which we haven't mentioned, but I think is worth thinking about, and it is sort of edging into the chatbot idea, is beginning to use these tools in a training context. So as you train therapists, give them the kind of virtual patient, the avatar that is responsive and interactive. And there's already a lot of excitement around doing that and helping to train people to do specific kinds of evidence-based psychotherapy in a way that can be done with a lot of fidelity and a lot of rigor, and done quickly as well and efficiently. So there's a huge amount, I think, that we can gain there. All of which is to say, and Matt, you and I have talked about this. I think we've come through this very interesting 3 or 4 years where so much of mental health care has moved online, has moved to digital. And that's great. It's democratized care, it's improved access, but it hasn't yet, I think, really improved quality. And quality is going to require the measurement piece, and it's going to require training. And this is where AI, I think, is going to have its moment for us. Initially, it's really going to help us on those two pieces to improve what we do and to ultimately offer far better outcomes.
Yeah, the training piece is really interesting to me because, for so long, med schools and, training programs have had to rely on, asking, paying med students $35 to come in and, present with, symptoms of, this or that. And so, it really, I think, reduces its effectiveness. Is the data pretty strong on this, using, like AI models and stuff for that kind of training, or is it too early to tell?
I'll turn it to my colleagues, Alidad and Fionn, to see if they have more experience. I haven't done this myself, but I know that there are a couple of companies that are deep into this and are pushing this idea of let's use these models as a way of improving the quality of psychotherapy.
A couple of comments. If we step back a little bit, I think the solution systems is going to be a combination of AI technologies. So generative AI with rule-based AI with other components is going to be the solution. One of the things that was mentioned, by the way, from Dr. Insel is, adding a face to the words. And that's really important, especially in the culturally sensitive conversations. And that's what we've developed. We've developed characters that represent that particular culture and community, speak the language, have different accents, are animated in a way that actually connects with the patient more so than just a little box that talks to you. When it comes to training, healthcare is still dispensed individually. What I mean by that is, and the educational component of that as well, what you learn at Mayo Clinic may not translate to what you learn at UCLA. Two completely different healthcare populations, environments, and that education and training has to be in tune with that particular population that you're going to address. So one of the solutions is really to put the control of these natural language models in the creator's hands, as opposed to some GPUs stored away, far away, where you only have limited access to. And the trick is going to be, how do you do that? How do you bring that powerful technology into a focused beam with enough guardrails and controls to be able to dispense the education that you want? Instead of OpenAI or GPT or a language model giving you the answer, why can I give you my particular experience and answer? So these tools can be very helpful, especially in semantic similarities and also in understanding sentiment, but the output, the narrative of what you want to go out should be in line with your particular narrative and your experience and education. And then on top of that, when it comes to simulation, it's important to also understand the environment, right? So I think in-person education is still critical, but identifying those gaps when you're having those meetings, those in-person one-on-one educational sessions is critical. We don't know what our students don't know. And there have been plenty of lectures I've given when I'm talking, and they're staring, and I have no idea what they know, what they don't know. So imagine a world of education where you get to understand the educational gaps before that simulation. And that could be dispensed in virtual reality, augmented reality, or even tablet form, depending on what type of interaction you're going for. One of the things that we're trying to understand is empathy training, and that's a lost art in healthcare these days. I mean, people who've been around pre-2007 in healthcare had enough human interaction and made enough mistakes to understand empathy and to be able to speak and learn how to talk to patients. But these days, with the siloed healthcare environment, it's really difficult to try to get that 31-year-old to understand what it means to have a chronic condition, to really sit there and look at the patient and be able to empathize, or deliver bad news at 2 a.m. to a family member. So we are working on technologies for empathy training, especially in virtual reality simulations that you can have as a student, and then you go out there, identify the knowledge gaps, and then practice with your real instructor as well. So on the training side, I absolutely think that there's so much growth to be done there, as well as on the educational side of our patients as well. One of the things I say is physicians think that patients grow out of the chair. We don't understand. We think they know everything we know, and they're nodding yes, but they just want to get out of that room sometimes because we're scary. Am I going to give them a shot, or am I going to hurt them before they leave? So creating safe environments and really educating physicians to be able to empathize, connect with the patients, regain trust, and bring them on the same playing field that we are as far as knowledge and education is one of the goals that we're going after. So much to be done. The future is bright, but a lot more work has to be done, obviously.
Yeah, the empathy thing is really interesting to me, because I think one of the criticism that you read a lot, people are saying in terms of what AI can do and can't do, and so they say, well, it can't replicate emotion, it can't you hear empathy frequently saying that AI can't do empathy, and therefore it can't replace these particular jobs. But what you're saying is that it's not about AI having empathy, but it's about AI tools being able to give humans a deeper empathy.
Yeah, so this, that publication that came out in Nature, and there was a study at UC San Diego talking about AI being more empathetic than doctors. Well, the point is we're not empathetic enough, right? And why aren't we? Because, if I write a quick email saying, yeah, you'll be fine, it's one and done, right? I don't even have the time to sit there and go, well, what's the best way of wording this so the patient feels empathetic, because I'm so overloaded, right? So imagine unburdening that component of my brain and then giving me enough time and space to be able to empathize. So yes, we're below what I consider is standard. And yes, the GPT set the standard on empathy, and we got to catch up to it. Absolutely. The other thing, by the way, not to overwhelm the conversation, the whole idea of this documentation, I call that the second opinion, or the co-pilot. I call that the third eye in the room. And by that, I mean, here's your opinion. So patient has an opinion. I read on Google, I should have the procedure. Doctor has an opinion. And then AI has an opinion. Talk about workflow and talk about, helping yourself. That could create a controversy that we can never be able to solve if we don't have appropriate guardrails and safety nets around this whole process. Because who's going to be right? Do you want to trust a robot? You want to trust Google's online article, or you want to trust the doctor? So many things that have to be worked out. And unfortunately, I think what's going to happen is that the regulation is going to come after all this is out there.
Yeah.
Just happen with social media and everything else. So much.
Sorry to jump in on that empathy point. An interesting anecdote I heard. Germany has done a lot of work on digital prescriptions, DIGAs, so you can prescribe digital apps. And a clinician I was talking to recently told me they did prescribe a CBT chatbot to a patient, and they said, no, actually, I prefer to use ChatGPT because it's more fun and it understands me better. And that's exactly that regulation problem as well. We have things out there in the wild, and as a clinician, you probably shouldn't be letting someone use ChatGPT because we have no idea, absolutely no idea, what it could be telling anyone. But that empty point, that CBT chatbot was probably deterministically designed, very medicalized language, I suspect, very one opinion put into it. So there is that clash on the patient side with what they want to be using. So yeah, it's a fast world. And I suppose to add to that, I do worry when I talk to clinicians, especially older clinicians, they're still kind of working out how do we go on Zoom never mind what AI is.
Yeah.
How even my friends in med school, they're getting nothing on this. They're seeing things in the papers, but there's no lecture on what is AI and how do we know that this output, to your point, Alidad, on the third eye, when do we know, or how do we train people to know that this is an appropriate thing for AI to be making a deterministic on, but if it's predicting the future and it has no training date on the future, then there's a problem. And what is training data and what is bias and what is drift over time and probabilistic drift? Are we going to change how we teach people? And when will that change happen? Because if it's in 5 years' time when we rewrite the curriculums, that's probably 5 years too late.
Yeah, let me jump in because I think there's sort of two threads here that are really striking to me. One is the resistance from the current workforce to use the tools we've got, right? And most of what we need currently, if we're going to improve the way that therapy is delivered or the way that any clinical interaction is delivered, is to capture that interaction, which requires recording what happens, either through a digital scribe or through very simple conversion of conversation to text, some way of actually capturing what's going on in the interaction. We need that. That's sort of essential. And it's remarkable how resistant many clinicians are to having that done. They don't seem to have a problem with their internet provider tracking where they go all the time on their phone and knowing what they do, or Amazon knowing exactly what their preferences are. But there's something sacred to them about their interaction with a client or a patient that they don't want anybody to know about, which is worrisome, but in fact the case. I mean, it's what we had to fight against in the surgical theater to allow people to actually see what's going on so we could improve surgeries. There's been enormous resistance in the world of mental health to allowing that third eye in the consulting room. And I think that is going to be our biggest challenge here. The second piece of this, which is so interesting to me, is how bad the status quo is. And it's not just about mental health, but healthcare generally. I was invited to come to a conversation about a month ago in Silicon Valley in Menlo Park to talk about the title was The Problems and Perils of AI in Healthcare. And there were about 30 of us. It was a salon in the evening after, that with very nice wine and very good food, where we sat around in a big circle, and mostly healthcare professionals, some very senior people from academic centers like UCSF and Stanford. And the topic was the perils, and the entire evening essentially was hijacked by a conversation with these healthcare providers talking about how difficult it was for them to get decent healthcare and how poor the status quo is right now. So on the one hand, you have this real resistance to a field sort of accepting something that actually could come in and be very helpful, right? Could save them an enormous amount of time, an enormous burden, and provide a report for the patient, a report for the payer, a report for the provider, all that stuff that you want. Do it in multiple languages and do it with great accuracy and great efficiency. Resistance to that. And on the other hand, you've got the experience of most of us, both as providers and as patients, being incredibly unhappy with the quality of care that's out there. And we're going to have to find a way to get past that resistance to adoption if we're going to solve that second problem of quality. It's just a remarkable moment, because we now have what I think is potentially a breakthrough tool for this field. It is, I mean, without question. And it's probably no other part of medicine that's going to be transformed as much by AI as mental health care. And yet it's a field that is it's so resistant. It's going to be hard to know how to overcome that.
Yeah, when about 7 years ago, my staff and I did some virtual reality demonstrations at the Colorado Health Symposium, and we were showing what was still some early early in development exposure therapy VR platforms, which there's a lot of those, and it was amazing to me how many therapists came up and said, "Oh, you're trying to take my job. That's all you're trying to do is," and we would explain, how it could actually help their job. They weren't buying it, and part of me thinks it was just classic fear of the unknown. But the interesting part was then when we asked them, how many of you do exposure therapy for like fear of flying with your patients? I said, "Oh, we don't do that. There's no way that we could do that because we can't take our patients out to the airport every session and things like that." So it was a tool that they almost conceded needing, but were so threatened by just from their own employment standpoint. It was fascinating to me. So I think you're spot on about that, Tom.
Yeah, at the beginning when we did surgical robotics at Google, there was the same kind of resistance. The surgeon said, wait a minute, you can take away my job. And then we had to explain, no, actually, this allows you to do 5 prostatectomies at the same time.
Right.
It's actually, and you could get reimbursed for all 5 of them. How about that? So it really is a question of helping people to understand how this allows them to do more and to do more efficiently. And I think that's been the real challenge. And some of the big, I know I just saw this blow up on Facebook around Simple Practice, which is the sort of the back end for 130,000 psychotherapists in the United States, saying that, by the way, our terms of service allows us to capture what goes on during that interaction, because they were wanting to say, hey, we want to bring something of value to you as a therapist and to your clients so that we can improve what you do. And enormous resistance, lots of people running away in droves, hiring lawyers to see if they could sue them. I mean, it's just there's some odd kind of lack of understanding, but also just utter resistance to the idea that anybody's going to know what I do when I'm in a brick and mortar office or now on Zoom with my clients.
On that, the resistance of having that third eye, one of that note is really a gestalt of what transpires. It's still more than just a conversation, right? One of the examples is if I have a patient who's there for a hand condition and they're drunk, right? I just smell alcohol in their breath. Well, how do I get that into the note and make it such that it's transparent, right? I mean, what happens is we usually write it, suspect, alcohol abuse or something like that, or we don't even mention it because I'm a hand surgeon by training. Just want to get that procedure done. How important is that to my day, right? So really, it's the equalizer of what I consider to be the truth between patients and the clinicians. It's the even-keeled understanding of what's going on. And physicians are resistant to that because they sometimes have to give up a little bit of that power that they have to be able to control the narrative. Is it good? No. Does it result in worse outcomes? Of course. I mean, if you don't send that patient if you don't have the ability to send that patient to rehab and really get them to sober up before having surgery, you're going to have worse outcomes. Having said that, I don't think that they'll be able to stop this type of technology. We won't be able to stop this type of technology penetrating the healthcare field. And speech is the first step. The next is going to be vision, right? So you're going to have cameras in the room as well. I don't know when that's going to transpire, but most likely we'll see some sort of a visual input as well to come up with really a gestalt of what transpired in the room. I'm all for that. I'm all for that transparency because I think sometimes the lack of transparency is what creates confusion and angst and creates a lack of trust. So a lot to be thought about. And your point is, so brave new future that we're looking at.
It's true. Fionn, I heard somebody on NPR when they were talking about AI stuff, and he made the point that he was saying, I really think that this is being overhyped and we're being, sold, stuff that really doesn't exist. And he made an interesting example, and I know it's not a true comparison, but he said, how many people have, dictate text messages on their phones and send it and have people write back and say, what do you mean pirate showboat that, that you're whatever it just appeared. And so is the technology really just in terms of like, everything you're describing around what it can do, around note taking and translation and stuff like that, is it there?
I think we've all seen those LinkedIn posts of kind of funny chat GPT things where it,
Yeah.
ask you how many mothers are in the world, and it's one child to one mother, so there's an equal amount of mothers to children in the world. These sort of edge case reasoning problems. In saying that, I suppose to Tom's point earlier, healthcare isn't amazing, right? There's a lot of problems out there. There's a lot of bad therapists. There's a lot of bad clinicians. There's a lot of problems. So I don't think it's right to hold AI to the standard of perfection and wait till we're only going to do this when it's absolutely perfect, because the world isn't absolutely perfect. And we need to my point on kind of risk reward, we need to identify where it's acceptable to put a little risk and that it may be wrong twice out of 10 times, but that 80% correctness is still bringing value add. And how are we going to double check that time when it is wrong? The tech is there in most cases, I think. Dictation, note-taking, that's been there for years. Like Dragon voice reading, I think most people would have used that 10 years ago. It's only gotten better. Things such as full teletherapy, we're not quite there. VR is getting better, especially like Apple Home. I think will democratize that. We'll see it not being a really expensive piece of hardware, but something everyone has. There's still edge cases, certainly, around kind of physiological and vision, but we are getting there, and we're getting there very fast, I would point out. I don't think it's right to just say, we'll wait and see what it's like in 5 years, because it's probably going to be there in 2. But I suppose one big part of this, and we haven't really touched on it, is regulation, right? The regulation is still quite old. How are we going to put things in place that are safe? Who determines they're safe? What measures are we using to determine they're safe? Because there's still, I suppose, looking historically, regulation is still grappling with digital therapeutics, right? We still haven't quite cracked how we regulate digital therapeutics. And now AI has suddenly come along and changed the whole landscape again. And the FDA, the EU is still, several years behind that. So how do we build regulation that can speed up and is also appropriate? And that's probably a question for someone above my pay grade, I suspect.
Yeah. Well, Alidad, you were going to say something on.
This I was thinking about this morning. This whole idea that Fionn mentioned about humans making mistakes and machine making mistakes. Humans have the ability to be forgiven, but somehow the way our brains work, we don't want to forgive a machine, right? I mean, if that app is not working right for a second, it's out. But if I'm late 30 minutes to an office visit for a patient and I come in and put my head down and look at them, go, I'm so sorry, they forgive me, right? So the expectation is different because it's still a machine. Now, when you use the machine for the human, then maybe it's a different scenario, but we're not there yet because our brains can still tell the difference between what is machine and what's not for the most part. And we won't delve into the whole state of mind theory with ChatGPT and the studies done behind that. But just want to bring up that point that Fionn mentioned.
Well, let's talk about the regulation, piece. Fionn mentioned, and it's, as you said, it's always has the same. Anytime there's a new technology, the technology gets developed, and then people say, "Oh shit, we don't have a compatible set of ethics, and we don't have any regulation." And of course, that's where we are right now with AI. And so there's not only the question of how do you regulate it, but who regulates it? Is it Congress? Are we asking the industry to self-regulate? And how do you we'll come to the ethics part next. But in terms of regulation. Whose responsibility is it, and does anybody really have all the tools and the knowledge necessary to be able to regulate something that is this new, this complex, and moving this fast?
Yeah, that's regulation, I think, is a great question. I don't think we'll be able to get in front of it because as it is, it's already happening. Take an example outside of healthcare for politics. OpenAI specifically says you can't use this technology for political campaigns, but people are already starting to develop, mass campaigns of letters and what in politics. So the regulation is always going to be behind it. I think one solution is really this open source model. Imagine if every single human being, 8.1 billion people, had the ability to tune their own language model based on their own data sets, right? I mean, we're not there. And the whole complex part of this is the alignment of the models. There's someone at OpenAI that's sitting there telling it, say this, don't say that. Now, are those ethical considerations, the societal norms, in line with my specific cultural and societal ethical norms? Maybe for 90%, but maybe not for the 10%. So putting the control of this technology in the creator's hands, in the communicator's hands, and their ability to be able to fine tune it, I think, is really important. But I think it's just mass confusion right now. And Senator Schumer just invited Mark Zuckerberg and Elon Musk to an AI forum. Who knows what that means, right? So we'll be chasing this for a little while. I'd love to hear Dr. Insel's point of view on regulation, because he's obviously been part of the government process in this whole thing, and I'm sure he's got some insights into what's going to transpire.
No, I wish I had some insights. I am a little cynical about what government can do here. I just think that it's too slow and there's a tendency to kind of miss the nuances that are important. And I do think there's a real urgency to this question. So Matt, I know you are deeply involved with this issue of thinking about how to regulate this space. There is a what question, but you've raised the who question. And the who question, I don't think we have the right answer yet. I don't think that there's yet a government agency. There will be. And I've written about how the FDA was founded in 1906, or how it started with the Food and Drug Act of 1906 and how it grew out of that. And that really came about at a time when the nation needed to know the difference between snake oil and medicine. And before then, there wasn't a difference, so there was no need. Well, we have that same issue here, I think, in the whole realm of digital therapeutics and digital mental health, and particularly now with AI. There needs to be some way for the public to understand what is safe, what is effective. It's not the FDA that's going to do that, though. They're not set up to do it. So we are going to need some entity that does that. Is it a new government agency? Maybe that'll take 5 to 10 years. We need something well before that. Could we create a public-private effort that does that, or some nonprofit? I think those are really urgent questions to answer, and someone now needs to jump into the breach. I don't know that it needs to be as extensive as an FDA, but I'll tell you the thing that has really intrigued me in looking at the history of the FDA. It was set up to be a consumer protection agency, and it is that, but where it became most impactful, most consequential, was it helped the industry to know how to develop drugs. It provided for the first time a pathway for defining safety, for defining efficacy. And it was that pathway that created the pharmaceutical industry. We need that in the realm of digital mental health. We need a set of guidelines that say, okay, this is what we're shooting for. This is what success looks like in terms of safety, in terms of efficacy. This is how we define those terms, and this is what we work towards. That will help all the developers as much as it will help for consumer protection and public insight.
Yeah, it's interesting, because the FDA has tried to, to regulate some digital therapeutics, and I think most people would say that effort has not been as successful as it needs to be, in part because we're applying the exact same approaches to evaluating rapidly evolving and iteratively evolving technologies, and using the same techniques that we've used to evaluate drugs and devices, and saying, okay, well, we need these multi-phase randomized trials and things like that. By the time it's concluded, either the financial model has changed on the back end, or the technology is evolved so much that it's like, okay, we'll get back into the queue. And it also doesn't really look at how these things perform in real world settings. That it's a much more controlled, incentivized settings that we're realizing now aren't as predictive of real world successes as we hoped it would be. Do you think the FDA, and this is speculative, but do you think the FDA just wants, like, hey, somebody else take this, or do they really, or are they looking to sort of like hold the they don't want the threat and want the want it under their purview?
Well, so to be clear, in the mental health space, there isn't anyone regulating that anyway, right? There is no agency that oversees psychotherapy. The FDA has
Right.
nothing to do. They don't regulate surgery. They don't regulate psychotherapy or anything related to mental health treatment except the drugs. That's the piece they do. And if you try to like this, we're going through this now in the psychedelic industry, trying to get the FDA to approve psychedelics. And their point is, wait a minute, you've also done therapy for these people. We can't touch that. So that's a problem. It's actually for them a bug. It's not a feature in the way that that treatments are developed. So it's a little odd to say, well, we know you don't regulate psychotherapy, but we want you to take a look at digital therapy and see whether that is something you should regulate. Now, obviously, they're not going to touch it. So it's a bit out of their purview. And I think actually it raises the larger question of has this whole field of mental health gotten to that 1906 FDA moment where we should say, hey, we actually have therapies that work. We have many that are nonsense, they're garbage. Is it time to put in some sort of regulatory framework so that patients know not only that CBT is an effective treatment, but that if my therapist says they're doing CBT and they're not giving me homework, this is not CBT. I mean, so it's partly educating the public about, oh, this is what fidelity looks like. And these are the therapies that actually work. The World Health Organization has tried to do a little bit of this, but there's been very little effort in the United States to provide any kind of a regulatory framework for mental health care outside of medication.
Yeah.
Just to just build on some of those points. So over here in Europe, we are seeing the EU put in place an EU regulatory body for AI. Now that's 18 months from implementation, probably another 3 to 4 years implementation period. I would worry greatly who will staff these agencies, who will be trained to staff them, and how they're going to operate. But those points aside, I think the public partnership model is really quite interesting. And we've seen that in digital therapeutics. We've seen the DTX Alliance, companies getting together and going, we're going to set the standards here, or we're going to work together, because by and large, digital mental health companies I've talked to, they want to help people. They truly want to help people, and they do want to work together. They're all solving the same problems when it comes to AI: bias, where you're getting your training data, probabilistic drift. We don't all need to be solving our own problems. We can work together a little bit on setting in guidelines, frameworks, thresholds. And I think I would love to see that kind of body grow in the next couple of years if there was interest there in other companies.
One of the things that I think about when it comes to regulation is this whole model transparency, right? I mean, how does it give the output? And we still, to this day, no one has the understanding of how these models perfectly work. There is some stuff about predictability and saliency, and we can maybe identify a layer that can give you the answer. This is why I gave this answer. But that transparency bit is a huge problem. And I think, when it comes to regulation, someone's going to want to know that, right? Why did it give that answer? Explain to me why therapy A worked better than therapy B. And we don't know. It just did, right?
Right.
Good enough. So a lot more work to be done. If generative AI improves my day 10%, I'll be happy, right? It's not going to give me that 10% extra, right? That's all I'm asking for, right? And those are the low-hanging fruits that we should go after. And again, at HIA, patient education is really the thing we're going after, because we know, bring that patient up to speed. So when you're having that visit, when I say, yeah, your whatever muscle, they know what a muscle is, right?
Yeah.
So much.
These are really great. These are really great points, Alidad. And I think so often these conversations end up saying, but is it going to be as good as a master clinician? And it isn't going to be. And we're not talking about that. We're talking about tools that can help a volunteer on a crisis hotline, that can help a nurse in a busy emergency room, that can help a primary care doc who's facing a complicated mental health question, who hasn't really had the training in mental health. But we know that most mental health care, these medical mental health care, like prescription of antidepressants, 80% of that is done by primary care docs who have almost no training in this field. So that's the problems that AI is going to help us solve in terms of clinical decision making, clinical support. It's not to replace the master clinician. It's just one other thing, because this always comes up in every conversation, is to talk about how the algorithms are biased and they're going to be bad for marginalized populations because they have not been represented in the training data set. That may be true, but it's really interesting to see how some of the data are coming out in the most recent studies, because whatever you might expect, it doesn't look like that. In fact, I just looked at this paper, I think it's now published by Limbic. It's a company in the UK that's using a sort of chatbot for text-based CBT. And the population that does the best and that has the largest adoption is actually the LGBTQ population, right? Which, by the way, has, at least in the United States, perhaps the highest suicide rate of any group of youth. 51% of the active interventions for a crisis text line last year were LGBTQ youth. It's amazing. I mean, this is really a high needs population, and yet they're marginalized. They're the ones who one might expect would feel the least empathy and the least engagement, and they are the ones who'd seem to do the best. I don't think that's because these tools are so great. I think it's because the standard of care is actually biased. The standard of care is so poor that they don't feel trust. They don't feel that they can go to the population of therapists or providers that are out there. So it's an indictment of us, perhaps, but it's important to look at the actual data when we're talking about these systems are in some ways biased or going to be unfair for marginalized populations, because so far, that's not what the data are telling us.
Yeah. Go ahead, Alidad, you were going to say something?
Interesting thought. What if your AI chatbot said, put the phone down and go for a walk? That's all it takes, right? I mean, we spend time on on our phone. That is contributing to our perception of the world, and this human brain has never seen that many data points entered at such a fast pace. So that is part of the problem, just being on the phone and being on the internet. My hope for all this technology is to really allow humans to interact with humans more often, as opposed to not. And that's really where I see some of this technology being used in a nefarious way, where you can't get off your phone because it's so interesting that you want to stay on that chatbot forever and ever. And that's really one of the dangers I see to humanity, is our inability to communicate and connect with other humans.
Definitely. And it sort of makes me think, a lot of it is, the potential in mental health anyway is about those things that are more hidden, and where you don't even realize that that AI is part of the process. So it's not like I know I'm talking to this to this bot or whatever. And really in that sense can improve the entire patient experience, because I know, like, when I ran an outpatient center, I can't tell you how many times I heard a patient complain and saying, oh, the person taking my vitals, was grumpy, or I had to wait, 30 minutes for my appointment. And they always would say, but my therapist is great, or my psychiatrist is great, but they still had a bad patient experience, even though they really liked their therapist and connected well. And so all the things you've been describing about being able to have a better note and more personalized, patient education materials and stuff that they send with them, if we can improve the overall experience, and they don't even see that it's AI doing that work, we've done such a service to patients.
Especially if it's in the moment, right? So instead of having a 4-week wait for your first appointment,
Right.
You can be engaged within 4 minutes. And these are the things that we just take for granted now, that people should have to wait a month when they're in acute crisis, or
Yeah.
that when they go into an emergency room in a crisis, that they're going to see somebody who actually has almost no training in mental health, and we just sort of say, oh, that's okay. I think there'll be a future in which we'll look back and we'll say, what were we thinking, and why would we
Right.
allow that to happen?
Yeah, because so many people, I read that we lose about 1% on wait lists in mental health per day. 1% of the people who are on a wait list, drop off, and most of them are not going to another provider. They're just saying, okay, this didn't work because, they got ready, they were ready to start. And then they, like you said, Tom, they, say, well, you have to start in a month or 2 months. If we can give people the ability to say, okay, you're ready to start, good. The starting line is right here now. You can start, start today. And I think we'll see a lot more people that remain engaged in their treatment.
I mean, if it was a broken leg, you wouldn't wait for 4
Right.
weeks, right? Well, so if it's a broken brain, why wait 4 weeks? But absolutely, and it's much more difficult to treat it 4 weeks out as opposed to when it's actually happening. So
yeah. We've got 3 minutes left, and for every question we've answered, I've written down 9 more. So, we should have made this, at least an 8-hour discussion. What we know for next time, but I think safe to say we'll be asking you to come back for a part 2 at some point. But I just in sort of a parting thing, what's one question that you think we should be asking about AI that we're not asking or people aren't asking loud enough?
I like to change the term AI from artificial intelligence to augmented intelligence. I think that will change a lot of perceptions. I'm much better with the technology as opposed to without it. I think that's important, so more of a comment than a question is my thought. Just changing that terminology, just don't call it artificial, augmented, right?
Yeah.
You're not me, it's just going to be a better me, more transparent me, more consistent me, more accurate me. Right? I think those are important points to take away from these conversations. And then this whole, what you started with saying, Matt, initially about, it's going to destroy the world and take over. You got to get rid of those fears because that's not going to happen. Humanity is here to survive, not to kill itself. That's my view.
Love that.
I would say the word transparency. Actually, be that model transparency, be that data transparency. Where is my data going? Who has access to it? How long is it going to live there for? I think improved transparency will lead to improved trust. And at the moment, we have a handful of multinationals building this tech. It will get better. There's a lot of companies out there. But I think transparency is the first step to that. And that will make the world better for everyone.
Yeah, not much to add. I think those are really important questions. I think this next phase, this next 9 to 12 months is really going to be about education and people trying to understand, so what is this and what does it mean for me? Is there really some way in which this can help me do my job? And we have to demonstrate that. To me, I think the big question isn't kind of where we're at now, but where we're going to be in 2 to 3 years. I think the technology is changing so quickly. I got asked by Microsoft to kick the tires on AI, their open AI products for mental health back in January. And every 2 weeks, I'd get an email saying, stop what you're doing. We have a new version coming. And every version was markedly better, right? And then they finally kind of stopped with what's now called GPT-4 or ChatGPT, the current version, which is kind of where things are frozen. But no question, in 6 months, the tools are going to be that much better. And in 2 years, even far beyond what we're seeing now. So I guess what I'm fascinated by is where does this go and how good could it get? And I don't think we fully yet even understand that. I don't think we quite are able to imagine all the things that might be possible here. I've had a couple, without going on at great length, a couple of personal experiences using this that just have blown me away. Like even just saying to GPT-4, I'm going to Paris with my grandchildren, help me plan an itinerary. And what came out was just like phenomenal. In 2 minutes, 7 days in Paris, and all, like where to eat and what to do and all. It was just really mind blowing how good these things can get. So I think we're just at the beginning, and I don't think we yet know where it's going to end.
Well, thank you so much, all of you, for fascinating conversation. As I said, I think we just scratched the surface, but a takeaway for me is certainly that I am really reassured and thankful that people like Fionn, Alidad, and Tom are working in this field and leading voices in it. And it certainly helps me sleep better at night when I think about the future of AI, which is really exciting. So thank you all for your time and for your work and for being here. And everybody who joined the webinar today, thank you for your participation, and check out vxvymentalhealth.com and get more information on upcoming webinars that we have. Thank you all.
Thank you. Nice meeting you all. Thank you for the opportunity. Can't wait for part 2.